Hello, everyone. I'm Caetano Marquezini from Brazil, talking to you guys for the 16th Ifso Journal Club. I have here with us Dr. Daniel Schauer, who's Associate Professor in the Department of Internal Medicine at the University of Cincinnati, and Dr. Davey Utterburn, that is Senior Investigator of Kaiser Permanente Washington Health Research Institute. We're going to talk today about a very interesting paper that it's very important because it enlightens the importance of the link between obesity and some types of cancer and the impact of bariatric surgery over it. So this was a paper published in January 2019, and it's called Bariatric Surgery and the Risk of Cancer in a Large Multi-Site Cohort. I would like to remember you all that this meeting is being recorded and will be available inside the Ifso website at a virtual academy. Remember you too that you'll have to log in, so you have to be a member of Ifso to get it, okay? After the presentation, I invite you all to type in questions that I will read to Dr. Schauer and Dr. Utterburn so we can make this a very productive hour or hour and a half, okay? So Dr. Daniel, thank you very much for you being here, Dr. Utterburn, and should we start your presentation, please? Thank you.
Great, thank you. So first, I just want to say I had no conflicts of interest, but the paper we're going to discuss was, the research was funded by the NIH and the NCI. I wanted to start just because I think a lot of people understand the obesity epidemic, but I think it's often overlooked that cancer is strongly associated with obesity. And here on the screen, you see the 13 cancers that the International Association for Research on Cancer Working Group has defined as obesity-associated cancers. As you look at this list, you'll notice that some are not on this list that previously were thought to be associated, such as prostate cancer. But these 13 cancers, there's solid evidence that they are associated with obesity. Postmenopausal breast, endometrial, ovarian, colorectal, kidney, pancreatic, liver, adenocarcinoma of the esophagus, multiple myeloma, gastric cardiac, gallbladder, thyroid, and meningioma. Now, the strength of relationship between these different cancers and obesity varies. The mechanism behind the relationship is different for many of the different cancers. Endometrial cancer has the highest relative risk when you consider patients who are obese with a BMI over 30 versus those who are normal weight with a relative risk of 3.4. And the preventable fraction is the percent of endometrial cancers that are due to obesity. So about half of all endometrial cancers are due to obesity. Esophageal adenocarcinoma is relative risk of almost 2, and just over a third of those are due to obesity. You can see with pancreas, kidney, gallbladder, postmenopausal breast, and colorectal on this list. Now, as we think about these obesity-related cancers, I think it's important to keep in mind that the obesity epidemic, some have thought that it had plateaued, but recent study that was just published in New England Journal of Medicine last month projects that by 2030, in just 10 years, that almost 25% of the US population is going to have severe obesity with a BMI over 35. Another 25% are going to have a BMI between 30 and 35. So half of the US population is projected to be obese by 2030. I think this is very alarming, and I think it's, while this is the United States, I think the rest of the world is seeing similar trends. And kind of following those trends, when you look at the annual percent change in cancer rates by age group on this slide here, so on the x-axis, let me get my marker here, we're looking at average annual percent change in cancer rate. This line is at 0. Anything to the left is a decrease in the cancer rate. Anything to the right is an increase. And it's broken up by age group here, but I think what's most important is looking at these categories. So here at the bottom, we have all cancers not related to overweight and obesity. So these are all cancers that are not one of those 13 that we discussed earlier. And you can see that the annual rate of those cancers is decreasing. However, when we look at all overweight and obesity related cancers except colorectal cancer, the risk of those cancers is increasing. So, I think it's kind of generally accepted that, well, the risk of cancer is going down in the general population. That's true for most cancers, but not those that are related to obesity. Colorectal cancer is a special case where, with the increased screening with colonoscopies, we're actually preventing those cancers. So of the obesity-associated cancers, 55% of all new cancers in women and 24% of all new cancers in men are one of these obesity-associated cancers. And it's been calculated that obesity is directly responsible for almost 10% of all cancers in women and 3.5% of all cancers in men. And this is a problem that's only going to get worse with the obesity epidemic. So the obesity epidemic is worsening. Obesity-associated cancers are increasing. The question becomes, what role does bariatric surgery play in reducing the risk of cancer? There have been several previous studies on this. But of those previous studies, in particular like the SOS, is using outdated procedures that are no longer currently done. And a lot of the studies lack important risk factor data for cancer, which I think is very important when you're looking at cancer as an outcome. Several of the studies have lacked adequate power to really dive into the question and look at specific cancers as well. So for these reasons, we undertook this study, bariatric surgery and the risk of cancer in a large multi-site cohort, where our goal was to establish a large geographically diverse cohort using high quality data sources, only looking at contemporary procedure types, and then applying some robust analytic techniques. So what we did was we used 5 sites of Kaiser Permanente. We had Seattle, Washington, where David Arterburn is from, Northwest, which is in Oregon, Northern California, Southern California, and then Colorado. And then for reference, for those of you who don't know, Cincinnati is over here. So the advantage of using data from the Kaiser Permanente system was that Kaiser is both the insurer and the provider. So they have all of the health record data within Epic at each site. And they also have all the administrative data where they know when patients are enrolled and they know when patients get care outside of the system since they're paying for it. So it's a very robust data source that provides great data for a nice longitudinal study like this. So we identified all the patients within these 5 sites who had bariatric surgery using CPT-4 and ICD-9 codes. And we looked back from January 1st, 2005 through December 31st, 2012. 2005 was when all these sites were on Epic and capturing the electronic health record data that we needed. We excluded those who were less than 18 years of age or over 79, and we excluded all patients who had a pre-bariatric surgery cancer because we wanted to look at newly incident cancer. We included all patients, or we excluded patients with a BMI of less than 35 at the time of their bariatric surgery, and we excluded those patients who were not enrolled 12 months prior to surgery within the health system, so that we had ample time to capture any comorbid conditions that we wanted to include in our models. After we identified these bariatric surgery cases, we went about identifying some controls. We electronically screened all 16 million enrolled members at these 5 sites. After we applied our BMI, age, and enrollment restrictions, we had about 1.2 million potential controls remaining. We took a random sample of 20 controls per case matched on BMI at each site, just to limit the amount of data that we were actually pulling. And after this, we had almost 400,000 potential matching controls. To actually match them to our bariatric surgery cases, we created potential matches using the study site, the gender, and the birth date, where the potential match had to be within 1 year of the bariatric surgery case. And we initially limited matches to those with a BMI difference of less than 5%. So we created all of these potential matches where each bariatric surgery case could be matched to, our range was from over 2,000 potential matches to, in a few select cases, 0 or 1 potential match. And the controls could be matched to multiple surgical cases at this point. We then wanted to find what was the best match for each surgical case. So out of all these potential matches, to identify the best one, we used something called the Elixhauser Comorbidity Index. And we chose the closest match between the surgical case and the potential control based on this Elixhauser Comorbidity Index. Now, the Elixhauser Comorbidity Index is just basically a list of 31 variables that are easily identified in an electronic health record that have been used to predict mortality for hospital stays. And in this case, it just kind of gave us an idea of the comorbidity burden associated with our matches, or with our controls in our bariatric surgery cases. And you can see by looking at this list of the comorbidities within the index, some of them aren't relative to this study, such as metastatic cancer and obesity. All our patients were obese. But it provided a nice way to match up our controls and our cases. So we used each control only once, and we matched up to 3 controls per case. And after our first attempt at doing this matching, 99% of our cases had 3 matches. And the Elixhauser Comorbidity Index, for about 2.5% of the matches, had a difference greater than 3. We were concerned that was a little bit too high, so what we did was we did a second run. We removed all the matches with an Elixhauser difference of greater than 2 and created a new pool of potential matches where our BMI difference window was increased from a 5% difference to a 10%. And then we rematched on the Elixhauser. So after this second run, 99.5% of our cases had 3 controls matched. About 0.5% had either 1 or 2 controls. And only 62 bariatric surgery cases had no match, and we ended up excluding them from our analysis. The outcomes we looked at were newly incident cancer, and this was identified from tumor registries at each of our 5 study sites. We had follow-up through December 31st, 2014. We looked at all cancers, and then we broke it down by obesity-associated and non-obesity related. And then for the obesity associated, we looked at individual cancers and reported those separately. So our analysis, we created Kaplan-Meier curves, which I'll show, and then did cost proportional hazards models. And all the models that I'm going to discuss today were adjusted for these variables we show here, which influence both your propensity for getting bariatric surgery as well as your risk of cancer. So now as I dive into the results, this table shows just the characteristics of our matched cohort. And you can see that we had just over 22,000 bariatric surgical patients identified that were matched to just over 66,000 non-surgical patients. And in these tables and in the figures in the paper, you'll see a standardized difference, which is used rather than a p-value when you are using such a large data set. A lot of times with p-values, very small differences will have a significant p-value. A standardized difference, though, kind of accounts for the sample size. And it is calculated as the difference between the means divided by the common standard deviation. And a standardized difference of greater than 0.1 is generally considered clinically meaningful. So in this case, our cohort is matched directly on gender, so as it would be expected, 81.1% of the surgical patients and the controls are exact. As far as age, we're very close, 45 and 45.1, and the standardized difference is 0.01. So this would not be considered a clinical meaningful difference. And see our body mass index was almost 45 for both groups. And the follow-up was a little longer in the surgical patients at almost 4 years than the controls. Now this table lists all of the comorbid conditions we report, and the details aren't real important except to understand that, for diabetes, the two groups were very closely matched. Hypertension, they're very closely matched. Hyperlipidemia, the bariatric surgery patients tended to have a little bit more and were more likely to, or slightly less likely to be on a statin if they had hyperlipidemia. And the bariatric surgery patients were more likely to have ever been a smoker. There were no other significant differences between the two groups. They were very well matched. When we look at the bariatric procedure types that we identified, almost 2/3 of the patients had gastric bypass. And when we calculate the percent weight loss at 1 year, it was about 30%. Over a quarter of patients had sleeve gastrectomy, and their weight loss at 1 year was about 24%. And then very few patients had the gastric banding procedure, about 6%, and their weight loss at 1 year was 13%. Now this is a Kaplan-Meier curve, and for those of you who aren't real familiar with them, on the x-axis down here we have time in months. So from the index date of when a patient had bariatric surgery or was matched to a patient who had bariatric surgery through our 10 years of follow-up, 120 months. And down here you see this is just for the match controls, and this figure, just to keep it simple for now, we have the number at risk. So initially, all 66,000 match controls were at risk of developing cancer. And as time went on, as people developed cancer or were lost to follow-up or were censored for other reasons, that number decreases. So by the time we're out to 8 years, we're down to just over 1,700 patients who are at risk of developing cancer. On the y-axis, we have cancer-free survival. So initially, no one had cancer. And then over time, this line slowly goes down as patients develop cancer. And out here at 10 years, just over 10% of patients had developed cancer. Now, because this line is up at the top and kind of difficult to see, we changed the y-axis so that it makes it look a little more dramatic, but at the same time, it allows you to see differences a little more easily. So when we change the y-axis from 0 to 1 to 0.88 to 1, you can see that the line is much steeper, and you can kind of see that patients are developing cancer over time at a fairly constant rate among our control group. So when I add in the bariatric surgery patients, they're in the solid line up here on top, you can see that these lines separate very early and continue to separate throughout our follow-up time period. And when we looked at our Cox proportional hazards models, the adjusted hazard ratio was 0.67 for developing any cancer among the bariatric surgery patients. The confidence interval was fairly tight, 0.6 to 0.74, and our p-value was less than 0.001 for bariatric surgery. So bariatric surgery was associated with a significant reduction in the risk of any cancer. Now in this Kaplan-Meier curve, we are looking at just obesity-associated cancers. So one of those 13 cancers I mentioned earlier. And you see the lines do separate early and get progressively wider apart over time. And our adjusted hazard ratio for any obesity-associated cancer was lower than for all cancers. It was 0.59 with a confidence interval of 0.51 to 0.69 and a p-value of 0.001. Now, other studies had broken down the cancer risk by female and male because the cancers that they're at risk for are slightly different. So we, in our analysis plan, had planned to do that analysis. When we looked at the interaction, though, it was not significant. So there was no significant difference between women and men in our analysis, but since we had planned to do this, we did report it. And for women, the adjusted hazard ratio was 0.64 for any cancer and was highly significant. For men, our hazard ratio is 0.79, and this was not significant. So women had a significant reduction in the risk of cancer, men did not. So what about specific cancers? So this table shows the hazard ratio for these individual obesity-associated cancers, listed here kind of on the y-axis. And on the x-axis, we have hazard ratio, with this solid line being 1, meaning that there's no difference between the bariatric surgery group and the controls. Everything to the right favors our control population as far as cancer risk. Everything to the left favors bariatric surgery. The confidence interval, the point estimate is represented by the solid square, and the confidence interval is represented by the line. So we're here where we have gallbladder cancer. We only had 12 gallbladder cancers during our follow-up. You can see the hazard ratio is 0.55, but the confidence interval is very wide because there were so few cancers. While when we looked at overall obesity-associated cancers, where we had over 1,100 of them, our confidence interval is very tight. So for some cancers, we had a significant reduction. So for colon cancer, where we had 105 cases during the follow-up, our hazard ratio is 0.59. For endometrial cancer, where we had 322 cases, the hazard ratio was 0.5. For pancreatic cancer, it was slightly less than 0.5. For postmenopausal breast cancer, it was 0.58 and was highly significant. And for esophageal adenocarcinoma, it's not in this table because we had 0 cases in our surgery patients versus 16 in our controls. And this was significant, but because there were 0 cases in our surgery patients, we cannot calculate a hazard ratio. So it's missing from this table. So how do these results compare to other studies? If we go back and look at the Swedish obese subject study, they reported out their cancer outcomes up to 16 years among 2,010 surgery patients matched to 2,037 controls. And these are their Kaplan-Meier curves looking at the cumulative cancer incidence over time. And for women, you see a nice separation of the curves, and the hazard ratio is 0.58. For men, the curves were very tight. They had much fewer men in their study. The hazard ratio is 0.97. There was a subset of the SOS that was reported out among the 1,420 women where they had follow-up of 18.1 years, where they looked at specific cancers. And as far as female-specific cancers, they showed a significant reduction, but for breast, they did not. Endometrial cancer, there was a significant reduction with a hazard ratio of 0.56, which is very similar to our 0.5 that we showed for endometrial cancer. Ted Adams and his group in Utah did a similar study where they had almost 7,000 gastric bypass patients matched to almost 10,000 severely obese patients. And they showed that the total cancer incidence was 24% lower in the surgical group compared to the control group, giving a hazard ratio of 0.76. But similar to the SOS study, they did not find a significant reduction in men. The reduction was only seen in the female participants. So when you kind of look at these 3 large studies, the hazard ratio for developing any cancer for women varied from 0.64, 0.58 to 0.72 across these 3 large studies. While for men, we showed a hazard ratio of 0.79, which was not significant, and the other 2 studies showed one that was closer to 1. There are some limitations to all these studies. Despite matching and adjustment, unmeasured differences may exist between the bariatric surgery patients and the non-surgical patients. And there's no data on procedure-specific effects on cancer risk. We did not have enough power to really break it down by gastric bypass versus sleeve gastrectomy. The comorbid health conditions that are captured by ICD-9 codes can underestimate disease prevalence and do not account for severity. And there's moderate missing data on weight, which could lead to biased estimates of the relationship between weight loss, surgery, and cancer. So in conclusion, bariatric surgery is associated with a lower risk of incident cancer. I think we have 3 large observational studies showing this, all with very consistent results. The effect is primarily limited to women, I think this is largely because we're seeing the largest effects for endometrial cancer and postmenopausal breast cancer, which are limited to women. And I think it's important to note that the absence of a statistically significant effect for men does not equal evidence of absence. There are fewer men in all these samples because more women are having bariatric surgery. And I think all the studies have been underpowered to really look at the effect in men. So of the specific cancers, postmenopausal breast, endometrial, colon, pancreatic, and esophageal adenocarcinoma are all significantly reduced after bariatric surgery. I'd like to thank the collaborators who worked with us on this project. Heather Fagelson from Kaiser, Colorado, Corinna Kobnick from Kaiser, Southern California, Betty Kahn from Kaiser, North Carolina, Sheila Weinman from Kaiser Northwest, our statistician here at the University of Cincinnati, Anthony Leonard, the statistician at Kaiser, Colorado, Dave Powers, Pandu Yanamula, who is a bariatric surgeon at Kaiser, Northern California, and then, of course, David Arterburn, who is on this conference from Kaiser, Washington. Thank you.
So thank you very much, David. It was fantastic, very nice. I have a first question from Dr. Jack Himpins. I invite you all that are with us, send your questions, please. It will be very nice to have your questions and make this meeting more interesting. So Dr. Jack Himpins is asking you guys, I think it was nice for you both to give your answers. Do you have an idea what the outcomes would be with a control group with BMI comparable to the nadir BMI of the bariatric participants? David, do you want to start? Daniel?
I can join in here. That was a wonderful presentation, Dan. Thank you for that. You know, I think the challenge, even with such a large database that we had, that weight loss of the magnitude that we're seeing in the bariatric cohort is relatively uncommon in the non-surgical population. So we have other studies of weight-related outcomes that are forthcoming in this cohort, comparing the matched patients and non-surgical patients. It suggests that large weight loss of 20%, which was the average at 5 years and beyond in this cohort for surgical patients is uncommon for the non-surgical patients. If we were to try to match those two cohorts together, it would be interesting to see if those patients have similar cancer outcomes. If we haven't done that, we would probably be challenged by the sample size of the non-surgical population having such dramatic weight loss and being able to test that question. But it is a very interesting question, and one that hopefully with improved efficacy of obesity pharmacotherapy plus intensive lifestyle programs, we may be able to see a greater proportion of patients achieving that. And I think one important point here is that there's up until these studies of bariatric surgery outcomes in cancer, there really weren't data showing that weight loss is associated with a reduction in cancer risk from any other type of study. And so this is important to the field of cancer epidemiology and clinical cancer care, because it indicates that there is this health benefit associated with weight loss that extends to cancer.
Okay. Daniel, would you like to complete anything with your observations?
No, I would agree with what David has said. We did have another paper that we published in the Journal of Obesity looking at whether it is the weight loss or the bariatric surgery that is associated with the cancer reduction. And in that paper, we show that it is weight loss that is driving the reduction in cancer risk, not necessarily the bariatric surgery. So those who lost more weight had a larger reduction in cancer risk. So,
Yes,
I think it leads to the question of, is it weight loss driven by bariatric surgery, or is it if a patient has weight loss without bariatric surgery, will they reduce their risk? I think they will, but those studies have yet to be done.
So you don't think for now that it's bariatric surgery, it's about the bariatric surgery and the effects it does on the whole inflammatory process on the body, that we know that is much responsible for all the modification of cells, but only reducing weight. Is that what you said?
I mean, that is what I said, but I think that the impact of bariatric surgery, like on inflammation and stuff, is related somewhat to weight loss. So I think, weight loss is a mediator in there for a lot of those positive effects. Not all of them, but for some of them. So it's complicated. So.
David, is that it? Do you agree?
I agree. I mean, I think the major driver is weight loss. Mm-hmm.
Okay. So, Daniel, could you please stop sharing your screen so we can get your still sharing screen? Could you do that? So the image could be larger for the guys who's watching. Just stop, up there. Okay, thank you. So there's another question here from Dr. Ahmad Bashir. So he's asking you guys, thank you very much, Daniel.
Okay.
Did you look at screening data before the initiation and after between the two populations and potential premalignant lesions? So this is something interesting. So did you do any screening for these patients that you included for premalignant lesions?
So we did look at screening data, particularly around mammograms, because we thought that the health-seeking behaviors of the two groups might be a little different, where those who had bariatric surgery were up to date on their screenings versus the control group who may not be as up to date. And what we found was that there were no differences really between those who had mammograms and those who did not have mammograms, certainly as far as breast cancer risk during our follow-up, or the effect of bariatric surgery on those two different groups. We did not look at premalignant lesions. I think that's an interesting question, particularly in regards to like the colonoscopies and stuff like that.
Gynecological screening too for women will be interesting. I don't know if you agree.
Yeah.
David, what do you think about that?
Yeah, it's a great question and something we were very concerned about in the study. It makes sense that patients who are seeking bariatric surgery would be more likely to have, other health protective behaviors like cancer screening compared to non-surgical patients with severe obesity. But we didn't see that in our data, and I think that reflects the fact that in the Kaiser Permanente system, there's a lot of quality metrics and incentives placed on having good or high rates of screening in all adults who are of the appropriate age for different malignancies. And so I think that, the rates of breast cancer screening, colorectal cancer screening are high across all groups and emphasized within that health system. So I think that's where we probably, that was a major driver in there not being a difference between the two populations, I think.
Okay. So just going ahead and discussing, I think it's very interesting you put down here the other studies, Daniel, and you highlight a lot about the difference. What's the difference between this study from the others? I would like you to put it a little bit more for the guys who are watching us, for you to explain why this study makes so much a difference from the other ones.
So I think what makes our study different is that we were able to have a much larger sample size, and that gave us more power to look at specific cancers, with, I think, adequate follow-up. The other studies did have good follow-up, but our sample size was larger, and in particularly comparing our study to like Ted Adams' study, I think we were able to match our patients a lot better. He just matched earn, gender, and BMI. We were able to match earn a lot more variables that were, I think, important when you're looking at a study of cancer risk. And then compared to the SOS study, we had a lot more power. The SOS study was not, when it was started, cancer was not an outcome they were considering. This was, a later thing that they added. And so it wasn't powered to look at cancer. And the procedures that they used, aren't being done, as frequently anymore. So I think, we were able to look at contemporary procedures with a much better matched cohort.
David, would you like to add anything to that comment?
Yeah, I would also add the multi-site, multi-state nature of the data, which was helpful, which added to diversity, particularly Kaiser Permanente and the Californias add a lot of diversity. It's one of the more diverse, racial, ethnic, diverse cohorts of bariatric patients that we have. The other piece that I would add is that we have data from a tumor registry. Each of our sites create a pretty rigorous tumor registry to identify cancers, which I think adds to the validity of the study in terms of making it much less likely that we missed incident cancers in this cohort because of the rigorous clinical tumor registry that's established.
Okay, great. So another question, I see that the mean follow-up was 3.5 years. So this was like almost 2 years ago when you stopped writing the paper. So you're doing still follow-up for these patients of this population. Do you think if we have like 10 years follow-up, anything will change with weight regain, that these patients like 20% regain all the weight? So you think, will this change the curve? What do you think? What's your opinion? This is why I asked the first question. So is it all about weight, or is it all about, bariatric surgery is really doing something different for these patients?
I think that's a great question. So, our average follow-up was a little less than 4 years. We did follow them up out to 10 years for some patients who entered the data set early. And over that time period, the hazard ratio did not change when we looked at all cancers or obesity-associated cancers. So that would imply that it is a durable effect. There is some weight regain, though, and I think it's a reasonable hypothesis that over time that the effect may decrease. We had a paper where we looked at breast cancer specifically, premenopausal and postmenopausal, and there we did see that the hazard ratio did change over time. So, I think that's something that needs to be looked at a little more carefully with a little more patients followed for a longer period of time.
David.
Yeah, this is a great question. And I think Dan's point is right. There's a fair bit of heterogeneity in the outcomes within the bariatric cohort. Most patients have substantial benefit, but there's a few who have a larger amount of weight regain. And we do need to study those patients and understand if there's differences in their cancer outcomes. We don't yet know, but I suspect, as Dan suggested, that there will be differences in the rates of cancer that are closely correlated with what is happening to their weight regain over time. But an interesting phenomenon that we found in the diabetes studies that we have done is that there's a legacy effect of bariatric surgery on diabetes, where even patients who regain significant weight and relapse their diabetes, they still have a much lower incidence of microvascular disease in the long term than patients who don't have surgery, or the patients who don't ever go into remission after their surgery in terms of their diabetes. I expect we would see something pretty similar here, that these patients, even though they might have weight regain, they're still going to have a much lower cumulative incidence of cancer over time than the patients who didn't get surgery. That's something we would love to test, though. I think it's an important study that needs to be done.
Great. Let me see if we have more questions here. Yes, Dr. Himpins is asking you guys, are there any cancers you would expect to actually increase in number after bariatric surgery rather than decrease? Especially male patients. What do you think about that?
Yeah, I think that's an interesting question. And in our data, we have not identified any cancers that actually increase. I mentioned that esophageal adenocarcinoma, we showed a reduction in that risk because we had 0 cases in our bariatric surgery patients versus 16 in our controls. And I think, especially with sleeve gastrectomy and the risk of gastroesophageal reflux disease afterwards, that there is some concern that that could lead to an increase in the risk of esophageal adenocarcinoma. We did not see that in our data, but we had fewer sleeve gastrectomy patients. Just I think around 25% were sleeve gastrectomy, and they were the more recent cases in the cohort. So we had less follow-up on them than we did the gastric bypass. So I think that's, it's a question that needs further investigation. But in our study, in our data, we did not see any increased risk.
Okay, David, would you like to?
Yeah, I think that's an important point about the sleeve gastrectomy. It seems like esophageal adenocarcinoma might be increased for that population, and we're beginning to see some anecdotal reports of that suggest that. But I think we need more long-term data, and we would hope to do a follow-up study that takes a specific look at that. I think the other point I wanted to make regarding the weight loss over time relates to this, which is that the sleeve and bypass in the longer term may have very different trajectories for patients. We have a number of studies with 5-year comparative outcomes that are suggesting pretty comparable weight loss in clinical trials, maybe a little less weight loss with sleeve gastrectomy in observational studies where people aren't randomly assigned. And I think we need more long-term data to see if the durability of the procedures is similar and whether their bariatric or their cancer, obesity-related cancer outcomes are similar or not.
Great. Well, there's another very interesting question about dietary habits that Dr. Athanasios Pantelis is asking you guys. And he suggests it would be interesting to search whether those who had low risk for cancer assume different dietary habits in comparison to those who hadn't. And second, such a large database of patients would be ideal for analysis through unsupervised learning models so as to retrieve hidden associations that traditional statistics may be unable to show. So what do you guys, David, would you like to start with that?
Did you say machine learning models?
Well, the first one was about diet, okay? So if you had supervised the diet, difference of those who had good results and all of that. And the second one is such a large database of patients would be ideal for analysis through unsupervised learning models so as to retrieve hidden associations that traditional statistics may be unable to show. Did you get the question? Okay.
Yeah. It's good. I wish we had some nutrition data. This is one of the limitations of the type of database that we have. We don't have a large population base. It's not collected routinely in clinical care, unfortunately. So we don't have the nutrition data, but I agree to have that kind of information on a large cohort like this would be very valuable. Perhaps something we can get some funding to add to a large cohort. I think the second question, unsupervised learning models, I think perhaps is referring to also what would be called machine learning models. But my thinking about that is just try to use statistics, use the power of computing to try to determine what factors are related to improved outcomes or predictive of health outcomes. And I do agree with that idea that we, in fact, we're doing some work in the case of diabetes where we're trying to understand which clinical factors predict long-term improvements of diabetes, not just in terms of remission and relapse, but also the micro and macrovascular disease outcomes. We would love to also do that in cancer. I think this would be really interesting for that, to understand the clinical characteristics that are predictive and to be able to provide patients with information about their risk factors that may be improved through bariatric surgery more than with non-surgical treatment. Dan, what do you think?
No, I would agree with you completely. We did not have data on diet, and I think that's a whole nother field as you look at diet and nutrition and cancer risk, and I think a whole can of worms there.
And we know it is important. Diet is very important today.
Absolutely, and I think there is some controversy and a lot of discussion right now about which types of diet are better, for both preventing cancer and then for patients who actually have cancer. And I'd agree with what David said regarding machine learning, and I think there's definitely some possibilities there.
Another question I have personally, there's a lot of concern about cancer, gastric cancer in the ruminant stomach when you have a bypass, and the excluded one. And I recently talked to guys from cancer institutes, and they were concerned about and recommending doing biopsies on the stomach where you have severe atrophy, maybe resect the stomach, and you have a very big cohort. Did you find any gastric cancer on the excluded stomach? I didn't see if you wrote anything about it in the study. David, what do you think about that? Because we're doing this surgery for 30 years, and we're leaving a lot of stomachs back with pylori bacteria and with gastric atrophia without any biopsies. So what are your thoughts about that? David?
That's a great question. Clinically seems plausible there might be a mechanism for increased risk there. Dan, I don't think we saw anything about that, and we weren't able to distinguish gastric cancers. I guess we could assume in all the bypass patients those are all well, I don't know if we could assume whether it's from the pouch or from the remnant, right? So what do you think?
No, you're absolutely right. We did not see anything in this study, but I think gastric cancer is a little more complicated where, with the altered anatomy, where is it coming from? And I think it would take a little deeper dive into the data to determine the location of it. And I think that's a very interesting question, though.
Yeah.
Okay, guys. So I think do we have any more? Would you like to make some considerations? What from each of you would you think would be for what key points would you like to highlight here to make this study folks go after it and read it and really get the answers they were able to reach here? There will be a lot of guys looking at this video recorded, and they should go there and look after these highlights. David, would you like to start?
Well, I think the key point here is that, patients really value cancer risk reduction. This is an important outcome to patients when they consider their long-term health. So this is something that I would advocate that should be brought up in clinical encounters with all patients with severe obesity, as this is a risk factor that's likely an important decision maker around whether bariatric surgery is a reasonable treatment option for them. We don't have that many treatment options out there that we can offer people to say, this is going to reduce your risk of cancer. So I think, having that information as something that's displayed along with other, major hard endpoint out there in terms of improved survival and weight loss, these are things that I think may help motivate patients. I think the other thing is that, this was an observational study. All the studies that have been done are observational. But we can't wait and say, let's wait till the randomized trial here before we start using these data with patients in clinical practice. It's just really unlikely that we're going to have a definitive randomized clinical trial to test these questions. It's it requires such a large cohort of patients to be able to test this, that it's just prohibitively expensive for funders to randomize so many thousands of patients to surgical and non-surgical treatment and to follow them up for cancer outcomes. We can continue to hope that there might be, but I think we need to assume there won't and move ahead and say, this is the best available data we have. It looks like a 30% or one-third less incident cancer, particularly for women. And that information needs to be disseminated and be part of the conversation about the role of bariatric surgery in preventing major adverse health problems.
Daniel.
Yeah, I'd agree with what David said completely. I think important take-home points are that obesity is a big risk factor for cancer. Over 10% of our control patients develop cancer during our follow-up. I think that's alarming. And we have an intervention here, bariatric surgery, that reduces that risk by about a third. And which I think for cancer reduction is a huge reduction. And bariatric surgery and weight loss works to reduce the risk of cancer. And I think patients need to know that. I think providers need to know that. And yeah, I think it's a very important public health message.
Guys, I thank you very much. I would like to stimulate you guys to go ahead with your big cohort for more years of follow-up. This is very interesting. Go after cancer in the ruminant stomach too for answers. This was the 16th Ifso Journal Club. I was here with Dr. Daniel Schauer and Dr. David Atterburn. I'd like to thank you guys to be with us this morning. All this here in Brazil is still morning, but where you guys are, I don't know what time it is, but be with us. And just remember, you guys, that this meeting is being recorded and will be available inside the Ifso website at the Virtual Academy. And you will have to log in to reach it. Okay, guys. Thank you very much, David. Thank you very much, Dan. Congratulations for this nice work. And until the next Ifso Journal Club, guys. See you there. Bye-bye, guys. Bye.
Thank you.
Thank you.